encourage you to pull out a blank sheet of paper, and we'll start this from the ground one. So that's not blank here. So I would turn it landscape sideways so that we have more space to work on. This, if we're doing innovations, when you walk in the test, this will be on there. It'll be about 15% of the total quantity of the grade. So since you know it's going to be there, there's usually two ways to go. Either people nail it or they really mess it up. There isn't a lot of in between. So they either take the time to learn it or they don't. So if you know it's going to be there and it's 15% of your grade, you should be able to bank on the fact that 15% of your grade is 100%. So this should, the fact that you know it's coming, be a fairly given set of points to help with whatever your end goals may be. Passing is a good one. So, next piece to that is, for every nerve ending that we have, if you can provide the list of muscles, the muscle or the list of muscles that go to that nerve ending, I'll give you half a point, which comes to like 9.5 points bonus. Merry Christmas. Which again takes an edge off of you getting what you need to get. And then the last piece is completely on a side note away from this. I really like having my course evals come back. So to encourage you to get them done, much like the announcement you may or may not have read on Blackboard, if we have 90%, which in a class of 8 folks means that we have 100% participation. Then if I get everybody to do it, then magically 3 points will show up on your final exam score. So that's like 12.5 bonus points that are built into a test. Yeah, that's nicer than I usually am. So, but that should help quite a bit. Good to go? So, brachial plexus. Oh, so I will let peer pressure commence. Last time I checked, we were at 4 out of 8 in terms of course evals for this class. I've already found 2 of the ones who had missed. Have they done it yet?
I did it.
Did it, Brenda? Oh, there you go. Yell at her. So that means that there's 2 other folks that are missing, and y'all can figure you out. There's 1. We've got 1 left. 3, 4, 5.
Hold on. I'm going.
Aaron.
Aaron, where's she?
She's working.
She's playing hooky. Alright. So on your paper. I'm just going to sit down now. My day is done. C5, C6, C7, C8, T1. Good? So first thing first, connect 5 and 6, C8, T1. And extend those lines out. My strong recommendation is so I'll walk you through section by section, but when you rebuild it, I encourage you to kind of build it, the skeleton, and then with each of those sections, go back in and mentally image what needs to be there. Certain things are easier to grab than others, certain regions are easier than others. So from this point, let's name things. So roots, trunks, divisions, chords, branches. And I can even go through and actually create the visual split of what each of those looks like. Good so far?
Yep.
Okay. So roots is the nastiest looking one. Hands down. It just is. So we'll start with, give me a 1 up, 1 down, right at the beginning of each of these. I think this is the one that I actually forgot to label in front. So each of these, I mean, again, you have to recognize that we're talking about the roots as they come out of the spinal cord at the spinal each of the individual spinal levels. So this closest in roots is pretty much like as if this was your spinal cord. So these are intrinsics. They're very small. They're dorsal rama. Guess I can stay. Dorsal thoracic. Labeling it once and leaving it alone, you don't have to put the names every single place. Easy enough. Next one of importance, though, is coming off of, we'll draw a line down from 5. We're going to have 6 and 7 joined in. And this is long thoracic. Long thoracic nerve goes to serratus anterior muscle. What's the role of serratus anterior? What muscle group is it in? We'll start there. Scapular stabilizers. What does it do?
Protraction.
Protracts the scapula. What is the other principal function?
Winging.
Winging. So if we end up having an inhibition at long thoracic, if we have an inhibition of serratus anterior, then that medial wing, that medial border will flare off of the thoracic cage. It helps hold it into the thoracic cage. Good thing to remember. All right, from there we're going to do one up and one down to finish off our time in the roots. Yes?
So for our bonus place along thoracic, we would serratus anterior.
There you go.
What about the other thing
I mean, if you've got those labeled once, then you're done for, that counts as,
there? That's the bonus points?
that's it. Okay? I mean, this isn't hard. So, one down. Phrenic nerve. Phrenic nerve goes to your diaphragm. So when the phrenic nerve freaks out, you get hiccups. Up here, dorsal scapular nerve, rhomboid major, rhomboid minor. I just looked at a picture that drew the brachial plexus going the other way, and it really bothered me. I'm so used to just left to right that doing it opposite hurts my soul. Welcome to the party. We're reviewing everybody's favorite topic. Good? So that's it for roots. That's enough damage for y'all. Okay? So, trunks. So I like my little mnemonics. Randy Travis drinks cold beer. Real trainers drink cold beer. Okay, trunks. One up, one down. This is subscapular nerve, subclavian. Anyone guess what it goes to? Subclavius muscle. That's suprascapular nerve. That one goes to supra and infraspinatus, both. of the things, once we get to trunks, divisions, and chords, we segment these by name as well. And so this is actually my superior trunk. This is my middle. And this is my inferior down here. So they're relative to the position in which they're found. So if we're looking at this being C5 here, down to T1 here, the superior trunk is the highest up. The middle is conveniently in the middle, and the inferior is the lowest down. Once we get to divisions, that's going to switch to more of an anterior-posterior, where my superior and inferior are going to come more forward anteriorly, and this one is going to stay posterior for the rest of the way out. So it's in relation to where those pathways are actually running out of and through the different lines. So in the divisions then, again, this one goes anterior, this one goes posterior, and this one goes anterior as well. But we get our first sense of like some fun to where major branching kind of integrates, to where we have from this superior trunk, a branch comes forward, backward posteriorly, and from the inferior we go posteriorly. So we have kind of communicating branches from superior and inferior that go back in towards that posterior. And then we also have a communicating branch coming off of the middle that goes forward to the anterior. So what does it mean? In this frame, somebody got a strike, and in this frame, somebody got a spare. Got it? Strikes always win, strikes are on top. And that's it for divisions. Okay. Chords. Lateral. Posterior. And medial. So posterior stays posterior. Easy enough. But we're going to have some fun drawing now. We're going to take a nice curved branch and go from our lateral chord down to our medial. And then give me one nerve off of each of those. So they're not connected to the posterior, they just arc. It's behind today. So this is my medial pectoral. This is my lateral pectoral. So the medial pectoral nerve goes to both pec major and pec minor. Pec major is a very large muscle, so it actually needs more innervation than just one nerve can get it. So lateral pectoral goes to pec major as well. So pec major, pec minor. Now off the posterior branch, we're going to give ourselves 3 nerves. And off of the medial, we're going to give ourselves 2. So this one is upper subscapular. Upper subscapular, and that goes to subscapularis. So the first is upper, the last is lower. Lower subscap goes to subscapularis. Teres minor. Oh, correction, teres major. Messing stuff up.
What is upper subscapular?
Subscapularis. So subscapularis is both of them. So upper and lower subscap, both of them go to subscapularis. Lower also goes to teres major. Major. So the one in the middle is called thoracodorsal. The thoracodorsal goes to latissimus dorsi. Dorsal, dorsi. Some word association there. Thoracodorsal nerve goes to latissimus dorsi. All right, and that's it for cords. Oh, no, I lied. There's two down here. Both of these are cutaneous. So, medial, brachial, cutaneous, and medial, antebrachial, cutaneous. So medial brachial cutaneous is going to go here, medial antebrachial is going to go down here. What's the matter?
I thought they were flipped.
Oh, are they?
Yeah.
Antebrachial is the second one. So medial brachial cutaneous, medial antebrachial cutaneous. But no muscle innervations for this. Cool, now we're done with chords. We get to do branches. So first let's do right here on posterior, right where branches start. We're going to write ourselves in the axillary nerve. Axillary nerve goes to deltoids and it goes to teres minor.
Wait, is it double check?
Axillary nerve, deltoid, and teres minor. Oh, I missed one. Okay, let me give you one addition down here. Dorsal scapular nerve. What did I tell you that was?
Rhomboid major.
Rhomboid major, rhomboid minor, and levator scap. You wouldn't listen to that guy somewhere. Okay. All right. So down here, top branch C5, C6. This is musculo cutaneous nerve. The name, muscle and cutaneous. The muscles are everything here. It's forward elbow flexion. It's forward flexion of the shoulder. So coracobrachialis, biceps brachii, brachialis. That set that's here on the over the humerus is musculocutaneous. It's the muscle part. The cutaneous part is actually skin sensation on the forearm, on the lateral forearm, down through here. So if you damage C5, C6 nerve roots, you're going to see a weakness in biceps flexion, strength, wrist extension, and you're going to have numbness into the forearm, which is why we focus on some of this. Within the eval class, you're going to do dermatomes and myotomes. So it's learning the pathways that like C5 is going to give you for muscle strength. It's the pathways that the sensory, the dermatomes, the derma, is going to give you for that nerve along that pathway. So if I suspect a neck injury and I assess this C5 nerve root is his weakness, then the myotome is deficient, and then we're going to see these certain muscles patterns go to be problematic. Yes, ma'am.
So for that one, for our innervation points, do you want us to write like those 3 steps?
Okay, so musculocutaneous, coracobrachialis, biceps brachii, brachialis, those 3. For the last 3 that we're about to do, I'm going to let you group those a bit more because there's a whole lot more muscles for each of them, and I don't need you. Coracobrachialis, brachialis, biceps brachii.
So we don't need to write sensation?
Don't worry about sensation. We'll just do it for the sake of knowing the muscles that go with it. Okay, one in the middle. This is radial nerve. So first piece that we want to look at is, well, the first trick of the trade in this is innervation for radial nerve. If the muscle's on the back of the arm standing in anatomical position, that's radial nerve. Done. Triceps brachii, anconeus, supinator, brachioradialis, anything that's on the common extensor origin, consider it back of the arm, radial nerve. No exceptions. So rather than learning those 14 muscles that go with that, it's on the back of the arm because you know where it's at, radial nerve. Easy. Last one down here, ulnar nerve. Ulnar nerve is your funny bone. It runs in behind your elbow on the medial side. Flexor carpi ulnaris. Flexor digitorum profundus, FDP, just to the 4th and 5th digit, which is on the ulnar side. And then everything in the hypothenar eminence, so everything in this compartment here. Because we have Guyon's canal, the deep ulnar branch goes in through that Guyon's canal. What makes up Guyon's canal? What what osteolandmarks? What bones?
Pisiform.
Yes.
And hook of the hamate.
Good. Pisiform and hook of hamate, deep branch ulnar nerve goes in there. That's all the little small finger flexor, abductor. So you can put in FDP to 4th and 5th, flexor carpi ulnaris, hypothenar eminence. So we're missing one. So from the top up here, from our lateral cord, we're going to draw a line in. From our medial, we're going to draw a line up, and we're going to create a new branch off of there, a new major nerve. So if you look sideways, then we've actually got the shape of an M. For the median nerve. So, through the median nerve. Median nerve is darn near everything on forearm flexors. Common flexor origin is all of them, except for flexor carpi ulnaris and FDP to the 4th and 5th. Pronator teres, pronator quadratus, flexor pollicus longus. You can do flexor carpi radialis, palmaris longus, flexor digitorum superficialis, and then FDP for 1st through 3rd. Well, 2nd and 3rd. So it's everything else. All of these tricks except for flexor carpi ulnaris and FDP to 4th and 5th.
So what do you want us to write?
So you can put common flexor origin, except for the 2 that you put down for ulnar. And then put down thenar eminence as well, because it's going to take care of the rest of the hand, as well as the adductor compartment. So it's going to be all of your thumb flexors, abductors, your adductor for the thumb, dorsal and palmar interossei on that side of the hand, all that kind of stuff. So thenar eminence works fine. Yes?
I have 2 questions. So, so you just for that one, straight complex origin, thenar eminence, we don't need to put like not the other 2?
Well, so I mean, when you write down older and you put in it flexor carpial
Yeah.
nervus and FTP, you can like common flexor origin, accept, then put those two.
Okay, and then the radial nerve, you can just write back of arm.
Back of arm works fine with me. Common extensor origin, whatever. Back of arm, because that includes ancones and triceps. Okay? So, things that make me happy. I like colors. If you can color code this, you make it so much easier for me to grade it, and I'm a little self-serving that way. So I'll throw you 2 bonus points if you're going to color code this for me.
Color code.
Do you figure out your system, whatever helps you learn? I'm not particular. But just bring colors to class, color code your drawing, and we're good to go. I think I'm up to like 14 and a half bonus points on this exam so far.
I mean,
Nobody's complaining, I get it. Point is, if you can work hard and learn this stuff up till now, I'm not looking to destroy you or kill you on the final. Good? So we make it on our way.
Why do you look so confused?
So if I'm doing this, my structure is the first thing I want. C5, 6, 7, 8, T1. Connect my pieces, extend my lines, give myself my categories up top. Roots, trunks, divisions, chords, branches. And then I would work on my skeleton. I know I have a lot of little stuff in here, I wouldn't worry about it yet. Trunks, I have one up, one down. Divisions, I've got a strike and a spare. Chords, I have an articulating branch that's got medial and lateral pectoral nerves. And then that leaves me with my distal branches. And then I just go through it section by section. I have an up-down on each one of these. I have long thoracic. I have one more up-down. We've already got that pair there. Under chords, there's 3 down, there's 2 down. Give yourself axillary. Give yourself median. And then go to town name it. So get each section visually appealing to you. Get the major chunks done. Trunks is easiest, it's pretty empty. Divisions is easy, it's a strike and a spare. And then under, just kind of create your system, and up, down everywhere, long thoracic and up, down. And go from there. Okay? Then just practice it, draw it out a few times. Once you have it, it's not that hard. The bigger piece is the names. The visual aesthetics of it aren't so bad. Aesthetics is the wrong term. Good? Easy enough?
Yep.
Okay. Moving on.
Question really quick. The suprascapularis, what does that nerve, the muscle?
So suprascapular nerve goes to supraspinatus and infraspinatus. Good? All right. you.
Bye.
Cowbell. All right. This tends to look a little daunting. A little bit. It's lovely. You hang on your wall. What we just covered is really the branching of the brachial plexus as it comes out into the axillary space. So your branches are somewhat beginning in that region. Your roots are right up in there. Plexus just means like it's an interchange where we have different interconnecting branching as these nerves come out and down. There's a cervical plexus as well. There is a lumbar plexus. There's a sacral plexus. If we get into sacral, it's really pretty easy to learn and remember, except it's getting into a lot of nerves that are doing pelvic floor musculature, things that we don't really work with much here. So especially those going to PT, you may very well see these again. I almost guarantee you that PT school is going to have you learn the brachial plexus. There's a very real chance that lumbar, cervical, sacral will be added to that as well. It becomes a little less helpful for me to push those because those muscles are not inherently something that we're doing much with. So where we go from here, though, is to identify this large piece. So we do need to recognize the nerves as they come into and take care of and move the lower body. So the first one we have is this absolutely ginormous dude right here called the sciatic nerve. I will tell you right now, you will see sciatic nerve as an option choice on the exam. Sciatic nerve is never, never, never a response for an appropriate innervation for a muscle. Ever. I'm only putting it there to mess with you. It's the only reason it's written on there. If you put sciatic nerve, I may just fail you on the exam. Do not put, don't laugh. Do not put sciatic nerve as an answer choice. Ever. Got it? Got it. Okay, so what do you know about piriformis syndrome?
It's when the sciatic nerve gets kind of smushed.
Kind of, sort of. Yeah, it creates sciatica potentially. So what is it about it being entrapped though? What's unique about the anatomy in that location? How does it get smushed? There's the piriformis muscle runs through that area. So if I go overlay the muscles so we can see it, I got to get you some gluten out of the way. So you see the piriformis sitting right superior to it. Now the sciatic nerve is actually made up of two branches. The tibial branch and the common fibular branch. And once again, you may see in many places the fibular perineal switch that we've discussed in passing before. So if you see common fibular or common perineal, they're referencing the same piece, same structure.
What are the two words?
Fibular and perineal, P-E-R-O-N-E-A-L. There you go. It's written up there now. Cool? Okay. All right, so where the piriformis comes out, it isn't always so perfectly, well, the sciatic nerve isn't entirely always created at that point. So the two branches, the tibial and common fibular, may actually be divergent until they go around the piriformis muscle to where it's kind of reaching around to grab on to then continue their path and the muscle runs in between them. And there's a certain smaller population in which one of the branches actually punches straight through the middle of the muscle. So that's how it's getting smushed. You actually have a population in which there is a major nerve that runs a lot of muscle that's actually going directly through the belly of a muscle. A great place for smushing, for impingement, for irritation. So being able to tie that back to the anatomy kind of helps. All right. So tibial branch, common fibular branch. Just like the radial in the upper body, really stupid simple way to remember stuff for a lot of it. If it's on the back of the leg, with one exception, it is the tibial branch. Semimembranosus, semitendinosus, popliteus, plantaris, soleus, gastrocnemius, tibialis posterior, flexor hallucis longus, flexor digitorum longus, tibial nerve. Simple. Back of the leg, tibial nerve. One exception. That exception is biceps femoris, short head. I'm going to hide some stuff out of the way a little bit. So this is long head right here, so I'm going to hide it and you'll see why. So sciatic nerve, and right about the location that it splits, you'll see you have the origination of biceps femoris short head. Biceps femoris short head gets common fibular as its innervation. They rise together, they ride together, they stay together. That is also the only muscle that common fibular by name is connected to. Directly innervates. Because shortly after that location, common fibular comes down, it wraps around the neck of the fibula, and then it splits itself. Right there. So common goes deep and common goes is superficial. So the deep goes into the anterior compartment. The superficial stays in the lateral. So what muscles does the superficial fibular nerve innervate? It goes lateral compartment, then you ask yourself what's in the lateral compartment. And I understand that's reaching back 3 months. But definitely, again, I like my groupings. So lateral compartment is what muscles? I'd attempt to say you're right, except I can't hear you. Yes, fibularis longus and brevis. Longus and brevis, the two muscles in the lateral compartment. So that means deep goes to the anterior compartment. What muscles does deep go to? So what muscles are in the anterior compartment? And always put yourself back into the position of, especially with lower, with lower leg and forearm. If I put a muscle there on top, then what's it going to be doing? It can only pull, it can't push. And so it's whatever it takes to pull this foot up, which means that we end up getting extensor digitorum longus, extensor hallucis longus, and we get tibialis anterior. Except there's 4 in that group. And the 4th, that is the 3rd. Fibularis tertius. Tertius means 3rd. It's the 3rd fibular muscle, but it's in the anterior compartment. So the 4th one that everybody forgets, that is the 3rd fibular muscle. It's like mental gymnastics, it's fun. So let's say we have a football player who dives in and hits somebody else right at the fibular head. And we get a fracture at the neck of the fibula. Or a soccer player, somebody swings hard, they hit high, and they crack the neck of the fibula. What's the risk? What are we worried about with that individual? If I hit and crack right in there, what's the concern? The nerve, yeah. If I damage the common fibular nerve, what muscles am I going to impact? What can't I do? What movements can I no longer do? Because if I damage the nerve, I can't control the muscles anymore. So what eversion from my fibularis longus and brevis? What else? Because this splits at that point, goes deep and superficial. So if I'm damaging the common, then I'm preventing either of the branches from communicating proximally. So if I'm hitting it on the common fibular nerve, then I'm impeding my lateral and my superficial and my deep from having any kind of communication. So what actions do I have a limitation with that? Eversion, because I cut off my fibulars. I cut off that superficial. So what do I have with my anterior then? With my deep then in the anterior compartment? Dorsiflexion, toe extension. Now there's an intrinsic down there as well that can help with toe extension, but the main one is extensor digitorum longus. What does tibialis anterior do? Dorsiflexion is part of it. What else does it do? Where does it insert?
Base of the metatarsal one.
About right? So at that attachment point, what else is that going to, what other action is that going to create? Inversion. So between tibialis anterior and tibialis posterior, those are largely my inversion muscles for that foot. So it's not going to completely inhibit it or prevent it, but it's definitely going to weaken my inversion. So you damage common fibular, you've lost eversion, you've lost dorsiflexion, and you've weakened inversion. That's a bad day for that individual. Somebody has an injury to the knee and you go throw an ice pack on it, you can also, because it's so superficial, really piss off that nerve, get numbness and tingling and burning sensations that go along with nerve trauma. So if somebody presents that way after you first ice them, you probably shouldn't put it there again because it's very superficial. Ulnar nerve is going to be somewhat the same way. It's so superficial that some of your treatment decisions may in fact impact that nerve. Okay? Now we come back and look at tibial. If I could get rid of gastroc, get rid of soleus, you can see how that massive nerve just kind of splits my deep and my superficial posterior compartments. So it runs right between them with communicating branches going to each of the nerves, each of the muscles that it needs to. Back of the leg, regardless of the compartment, hamstrings, tibial nerve. Very, very easy. Except for biceps femoris short head, which arises at the same place as you split common fibular off of tibial. All right. So that covers back of the leg and all the lower leg, which means we have two more major muscle groups we need to kind of figure out. Femoral triangle. What are the borders? Guinal ligament, sartorius, adductor longus. Got it? Inguinal ligament, sartorius, adductor longus. Creates a passageway through which a pretty major series of structures goes. What goes through the femoral triangle? Femoral navy. Navy or navel, whichever you want to do it. Navy. Femoral nerve, artery, vein. N-A-V, navy. Good? So that means the femoral nerve is findable right inside that triangle. Not there. Probably not there. Oh, there we go. Found it. So anything that nerve comes near, it's pretty much going to. So to start, all of your quadriceps. Vastus lateralis, intermedius, medialis oblique, rectus femoris. Sartorius sits on top of it, that gets it as well. Pectineus, right here, well, that sits underneath it, it gets femoral nerve as well. And iliacus. That's a lot of stuff from that one nerve. Probably not a good thing to skip in. What's the last muscle group we've skipped for the upper thigh, for the thigh? Got our hamstrings, back of the leg, tibial nerve. Anterior thigh is femoral. So what's left? What are the muscle group? What are we missing? What other actions are we missing?
Rotation.
Rotation. Yeah, so external rotation, I mean, we could do that if that's what you want me to. So the little guy's back up in here. So remember we have all these little guys in here? If we did sacral plexus, we'd have all of that figured out. Nerve to piriformis, nerve to quadratus femoris. For the most part, that's largely it. I'm not going to worry about this. Glute, we can do, there's a superior and inferior gluteal nerve. They both hit glute max. Superior goes to pretty much everybody else. So there's superior gluteal up here, going into my gluteus medius. I hide it out, and you'll see that inferior goes into gluteus minimus. So there's a superior and inferior gluteal nerve. The last one that extends and travels is your adductors. How many adductor muscles do we have? Five of them. What are they? Adductor brevis, longus, magnus. What are my other two? Gracilis, and it's my highest one up. Pectineus. Okay? So pectineus, we've already mentioned, it goes to femoral nerve. Obturator nerve gets the rest of them. Obturator foramen, obturator nerve. Obturator foramen is that big donut hole that we have down at the base. From the rami, shield, pubic rami. Obturator nerve. And that goes to the rest of my adductor muscles. Okay? And we can leave it at that. So let's peel off some muscles. Let's get rid of some nervous structures. So you glance back and then add in all kinds of fun cardiovascular structures. So what we absolutely need to do is know where you can take a pulse. to know enough of the branching of the system that you can figure out how to manage vitals as well as manage bleeding. So big old heart hiding in here. Off of the aorta. Once you select. Cool. There we go. So you have this aortic arch. And on the left side, you've got the common carotid that goes straight up. You've got the subclavian artery which cuts over. And on the right side, that third major peak, you got the brachiocephalic, which really just splits into the right carotid and the right subclavian. What we need to focus on at this point is that, for the most part, this is like a street changing names. Based upon the region that we're in, it changes the name that we're in. So subclavian artery is under the clavicle. And then progresses into the axillary artery because it's under the armpit in the axillary space. And that just changes name into the brachial artery as we hit the humerus, the brachial region, right? So first place we can take a pulse is off of those carotid arteries. Either side of the esophagus, you've got sternocleidomastoid that comes down. Carotid artery is in that crook between the esophagus and the SCM. Easiest way, strongest pulse, closest to the heart, largest vessel. Okay, once it transfers away from that, you go through subclavian, you get into axillary. Axillary comes into brachial. Brachial arteries are next place. Inside of the arm, so you've got anteriorly brachialis biceps brachii, posteriorly triceps. Right in between, you've got direct access to the humerus. You push into the humerus, you're going to feel a pulse. If you're working with an infant, this is where you take a pulse. As people grow, this becomes not the easiest. Radial artery is much easier to take a pulse at, or carotid. We don't like pushing on kids' necks too much, so I'm not doing that. If I have distal bleeding that I can't control, it's at this location in the brachial artery that we want to stent flow. Shunt flow. There we go. Got the right word eventually. So from there, brachial splits. And we end up with a radial and an ulnar artery. Radial follows a radius bone. Ulnar artery follows the ulnar bone. Now, we don't use the ulnar artery for a pulse because if you palpate on yourself, you'll feel that there's a lot more tendons that cover up that side and that space. You can't get to it. If you go radial, then we get this nice little groove that we can kind of drop our fingers into to feel underneath it. Now, radial artery then crosses over, and it goes into that through that anatomical snuff box that we've discussed and felt pulses in before. So you can actually find it there by squishing it against the scaphoid, and it actually goes up into the webbing over the adductor muscle. You good? Femoral, posterior tib, dorsalis pedis. Good to go. Goes through the webbing, posterior to the adductor muscle, and you can feel it in there as well. So The main thing to know is that radial artery, major place to take a pulse. You can't feel it distal. All right. Pull back out of there. And we come anteriorly. So if you watch that descending aorta, you get into the abdominal aorta, the thoracic aorta into the abdominal and descending aorta, you can actually feel a pulse there. So if you lie down, or you have your person lie down and get them to relax if their abs are giggly and laughing, then you can't do this so well. But if you take 3 fingers or 2 fingers and you just put it, stick about a hand width above the umbilicus, you can actually feel the pulsing from the abdominal aorta. I mean, it's a pretty massive artery that's coming down. And then it splits. That. There we go. So my common iliac, which goes internal and external iliac. And then conveniently, this massive artery right at the location of the femoral triangle becomes the femoral artery right here. So, femoral triangle, nerve, artery, and vein go sliding right on through. So again, you can take a pulse in this location. And this is also if I have distal bleeding in the leg where I'm going to apply pressure to try to help shut that blood flow. So, continuing down, we're going to hide out a couple muscles so we can see what's going on deep. So there goes sartorius. Here goes vastus medialis oblique. And that leaves us, I mean, you're going to intermedius, or rectus femoris and intermedius as well. So if you remember that adductor magnus had that really funky kind of hole right in it, to where it reached down to attach to the femur. Then there's a big gap before it grabbed on that medial epicondyle. Well, that big hole is actually the adductor hiatus, hiatus meaning hole. It's a passageway for that femoral artery to drop in behind the knee where it's more protected. So that adductor hiatus, as soon as it does punch through, it's now in the popliteal space, which means it's become the popliteal artery. So we've got 2 more branches to concern ourselves with. So once we get past the knee here, I'm going to pull gastroc out of the way. Pull some soleus out of the way. So we're looking at the posterior of the leg. We go from popliteal artery to tibial artery. It splits at that location where we have anterior and posterior tibial arteries. Anterior drops over into the anterior compartment. Posterior runs in between the deep and the superficial posterior compartments. There's one other little branch that comes off that follows the fibula, which is the fibular artery. So, femoral artery goes to the adductor hiatus, becomes popliteal. Popliteal splits anterior posterior tib. And posterior splits off the fibular artery as well. Who can tell me something about compartment syndrome? What's it come from? Is that other class? I don't know. What's compartment syndrome?
You get hit hard in the leg, and then pressure builds up, and
Yep. What's it do? What are the symptoms? What are the risks?
Can I ask anybody?
Yeah. I mean, I've got 4 muscles, 3 muscles higher up, wrapped in saran wrap that doesn't flex. Then I'm going to go and traumatize the poor set by kicking the crap out of it. This is acute versus chronic, and chronic is a little different, but the same basic idea. I've done something to create swelling in a space that can't handle swelling. So what is my concern? Blood flow is a major one. What's another? Nerves. So anterior tibial nerve goes to the anterior compartment. What nerve goes through that compartment? Oh, check those notes.
The deep common fibula.
The deep fibular. Commons when they're together, when they split, is deep and superficial. So the deep fibular goes through that compartment as well. All right, so let's say I'm cutting off blood supply. Where does that blood go? Well, we can follow it because we haven't done it yet. If I flip it over, I need to get tibialis anterior out of the way so I can go find that artery. So we tag it. So this is where that blood goes. If I zoom in, I need to get a retinaculum out of the way. You can see it splits, becomes a dorsalis pedis amongst other things. So the dorsalis pedis is the next location that we can take a pulse. So if we go and find the first ray, the first metatarsal, and we slide just inside of it, in between the first and the second, so come off of extensor hallucis longus tendon and go in to that space, you can find the pulse. It's a harder one to find because it's a much smaller artery, but it's there. It's the one that most nurses will go, oh, yeah, it's there. Whether they felt it or not, they mark that spot. Because it's not always the easiest to find, but it's in there. It's right off that extensor hallucis longus and drop in off of the bone into that soft space. So if I'm impinging anterior tibial artery higher up because I just had somebody kick me in the shin, what symptoms am I going to get if that pressure is exceeding my arterial pressure? If I'm cutting off blood supply, what happens? We can try it. Okay, so grab your wrist really hard and just hold for a minute. Pump your hand a little bit. All of a sudden it starts changing colors. Things get cold. You're cutting off circulation. And I get all kinds of fun, happy stuff that happens with that. Like coldness and cell death and losing your foot. Bad day. Because it's cutting off circulation to your foot. At least the anterior, the top part. Good, probably a problem, right? Okay, so acute compartment syndrome, medical emergency, we're cutting off circulation. What happens if that pressure is impeding the nerve intervention? Then the nerve's ability to communicate with the muscles. If the nerve can't talk to the muscles can't do what? Contract. And if I have too much swelling, then I can't contract the muscles anyways because they can't do the whole sliding filament theory thing. So what do I expect to find with somebody who either can't contract or has a weakness in contraction of those muscles? Let me give you a hint, weakness. So do manual muscle testing, and on dorsiflexion, you're going to have limitations. When they walk, because they can't dorsiflex, they'll have drop foot. That foot drags on the ground because tibialis anterior can't pick it up. Signs and symptoms just by knowing which vessels pass through which areas. All right, so flip that over. Other side. Find us a posterior tibial artery. It drops in behind the medial malleolus. If you find the medial malleolus and go just behind it, you can catch the pulse in there for that. That's the last pulse we need to know, posterior tib. Good? So, pulses. Carotid, brachial, radial, femoral, posterior tib, dorsalis pedis. 6 things. Good? That's as much damage as I need to cause you today. Next class, we're not going to add anything new. Next class, just review whatever you think you might need to go over. I have 2 sections of this class, as you know. So if you have any desire to take this exam at a different time, then that's easiest. Yours is slated for Thursday at 10:45. My other class is slated for Monday at 10:45. So if you'd like to be done earlier, feel free to just step into 217 or maybe the computer lab if I can grab it real fast. If I haven't already. So if it fits your schedule better, then great. If you need to reschedule, then just let me know. That's what I got. Any questions? Course evals, please do them.